I am Jan Esther, a midwife from South Sudan working for MSF South Sudan. Currently, I am working in pediatric department. I am going to present a case of severe malaria with multi-system organ dysfunction. So this presentation is going to be focusing on presenting complaints, is to present illness, past medical history, family and social history, clinical manifestation of the condition or the disease, clinical examination, review of the system, pathogenesis of the condition, laboratory investigation, medical or clinical management of this case, nursing interventions, and complications of the conditions. So, this morning, we received a 4-year-old male child residing in Malakal village of South Sudan, malaria endemic region or area, brought to the MSS supported healthy facility, that's to say pediatric wards, by his mother. So on arrival, and patient was so sick looking, and immediately the nurses on duty and the clinical officer admitted the child in pediatric, of which on 19th of June 2026 at 9:30 a.m. From there, even the pediatric doctor was informed to come and review the case. Then we are going to look at the presenting complaints. The caretaker said that the baby developed a high fever for 5 days, inability to feed or to take any oral shift or water, had 3 episodes of generalized tonic-clonic convulsions within the last 24 hours. And the child also passed a very very dark urine and little look like Coca-Cola. This is according to the mother during the consultation. Then we are going to look at history of present illness. The illness began 5 days ago with a sudden onset of high fever, vomiting, and the caretaker tried to manage the fever with the oral paracetamol, which never worked well. Now, over the last 24 hours, the child became completely unresponsive, suffered multiple seizures without fully recovery of consciousness between episodes. And the child also stopped tolerating or taking any oral fluids or food, according to the mother. Then, we are going to see past medical history. According to the mother's report, it said no history of chronic illness such as sickle cell anemia, epilepsy, congenital heart disease, no prior admission for severe malaria incidents happened. Though the mother said the child has 2 episodes of uncomplicated malaria treated in the first year. And this condition was successfully treated with the oral antimeter lumefantrine. Now, regarding surgical history, no any trauma or surgical procedure or incident happened, according to the mother. Then it's also important to look at the allergy. No known drug or food or environmental allergies been noted by the mother regarding the child. Then we also had to look at the birth and developmental status of the child. According to the mother, she attended a full antenatal services during the last pregnancy. And she also gave birth to a full-term baby, this baby that admitted today, spontaneously vagina that she obtained. at a local health center. No any incident of or any complications reported by the mother during the labor or puerperium time. Though the mother said the baby obtained 2.8 kgs of which was normal. Then we are going to look at the neonatal period of this baby. No history of neonatal jaundice, prolonged birth asphyxia, and neonatal sepsis. Then we have to see the developmental status of the child. Yes, according to mother, the mother said a baby achieved all age-appropriate developmental milestones, such as gross motor, fine motor, language, social, on time. Currently, this baby can speak full sentence and could also run without support. This is according to the mother. And in regarding this presentation, it's also very important to look at the nutritional and immunization history. The mother, according to the mother's report, the child benefited on exclusive breastfeeding for 6 months, followed by supplementary feeding with the family's food step, such as the millet porridge, the beans, green vegetables, fruits, and no any significant of acute malnutrition prior to this illness. Currently, even the body weight is 15 kilograms, of which it suits within the normal range of normal range weight, according to the World Health Organization weight for age growth chart for this child of 4 years old. Then now we had to see immunization status. According to mother's report, the child was fully immunized or vaccinated according to the National Expanded Program on Immunization schedule. These vaccines that included BCG vaccine, diphtheria vaccine, hepatitis, that's to say, yes, even this pneumococcal, including measles at 9 months. This is the report from the mother. Then we are going to see the family and social history of the child. According to mother's report, a child lives with both parents and 2 older siblings, of which 7 years and 9 years. They live in a wall house with a congregated iron sheet roof. And the family lives near a swampy area with stagnant water, which is a risk for mosquito breathing area. Then we also look at the malaria preventions. How are this child being protected? Now, the mother said the family owns a long-lasting insecticidal nets. However, the mother also reported that the person frequently slept without a net during the first month due to the high indoor temperature, this terms of South Sudan. And the other siblings are currently healthy with no active fever episodes. Then you have to see at the socio-economic status of this client or the person. Both parents are small-scale retail traders within the local market, and they are getting a clean water from a nearby communal Buako. This is according to the mother. After looking at all these histories, we have to look at the sign and symptom of this baby or this patient of ours. So, there is a high-grade hyperexia, of which axillary temperature was taken 39.2 degrees Celsius. This temperature contributing to the increased metabolic demand and lowers seizure threat score. Also, another sign is a severe tachycardia, of which the pulse rate 140 beats per minute. This is an active physiological effort to keep the cardiac output stable, despite severe anemia and volumes lost, or the blood volume. Then another sign is also the tachyphonia, which is indicated by 48 beats per minute. The child breathes rapidly and deeply without pulmonary obstructions to clear out the volatile acids out of the bloodstreams. That's why that child struggles very hard and in that difficult moment to breathe out. Then after, these are the major and the main clinical signs and the symptoms of this case. So we are going to look now at the clinical examination. Generally, the child or the person critically look ill, lethargic, and deeply jaundiced. This jaundice has been indicated by this icteric sclera that presents yellow. Then, on examination of neurological system, blood type coma score of 2 out of 5, and this where there's unlocalized response to pain, even abnormal vocalization, including mild neck stiffness that are present from the baby. The respiratory tract examination. There's tachyphonia. Yes, the baby has a 48 breaths per minute with deep acidotic breathing, and there was a clear lung on auscultation, of which ruling out pneumonia or bacterial pneumonia. So we also look at this examination of the cardiovascular. That was our tachycardia. The heart rate of the child increased up to 140 beats per minute, and there was a delayed capillary refill over 3 seconds, and also there were whole extremity present. This whole extremity is indicating shock in this child. Then we are going to review the system. So one of the systems that we are going to begin with is the central nervous system, and this one to assess the level of the consciousness. This has been evaluated using a pediatric Blantyre coma scales, and this is the standard one in children, and the baby scores a critical 2 out of 5 because the baby eyes response could not direct or could not track eyes towards sounds and visual stimuli. When we look at the bubble response, yes, the baby was very weak on cry, and when a painful stimulus been applied, it's like the pricking this baby, and the baby could not weakly. Then the motor response, the child withdrew limbs away from a painful stimuli, but this child could not also locate exactly where the pain is coming from. Obviously, it is even squared 1 over 2. Then we look at the pupils. It was equal and round and reactive to light bilaterally. This it tells the clinician or indicates that the brain stem is still intact and intracranial pressure has not yet caused pitoconation. Then we look at the reflexes. There was a fluffy muscles and bridged tip tendon reflexes. It was 3+, with the bilateral upwards extensor plantar response, which is normal, which is common following recent status epilepticus or emergent epilepsy, of which we have to rule out. Then we look at the cardiovascular system. The capillary return or the refill took time or took minutes over 3 seconds, and there was a weak peripheral pulse, and the hands and the feet are cold on touch, of which is pointing to systemic shock. Now we have to go to review the respiratory system. Yes, on inspection, the child had a very deep and rhythmic breathing. However, there are no signs of air passage blockage, such as subcostal recession, intercostal retraction, or nasal flaring. Then we are going to see the auscultation. What did we found and what was found in the child? There was a normal vesicular breath sound bilaterally, which means the lung fills and the chest was clear, no any crepitations, even oozing. So this is directly isolates the hypotonia, tachypnea as a metabolic issue rather than a respiratory infection like pneumonia. So not again, we could go far and look at the gastrointestinal and abdominal examination or the review. Now on inspection, the abdomen appeared flat, move symmetrically with the respiration. No dilated veins are visible. On palpation, the abdomen soft but slightly head tender. At the left side or below the right costal margin. Then there was a little bit of a slight palpable mass that could suspect hepatomegaly. Then at the left side of costal margin, there was also a palpable mass that could suspect splenomegaly. So if this splenomegaly happened because this organ is trying very hard or working very hard to filter out the distorted red blood cells and capturing mechanical destruction parasites. So not only that, we are going to look at the mucous membranes. As we said, there was pallor, conjunctiva pallor, and the sclera. And sublingual surface displays this deep yellow. This reflecting high level circulation or circulating bilirubin level from the broken red blood cells. Then the skin table, it was also reduced. Then this was over 2 seconds to flat back or to return back, confirming significant dehydration, and that could be because of the vomiting or poor intake of the fluid or the food. So now we are going to see the pathogenesis of these conditions. How does these conditions happen? Now, when we are going to look at the pathogenesis, we are going to go to look at the cycle. Now, according to this pathogenesis, or according to the progress of these conditions, when the Plasmodium falciparum parasites enter the bloodstream via a mosquito bite, it usually triggers and invades healthy red blood cells, that is to say the erythrocytes. So these erythrocytes, this is where the parasites have to survive and replicate. As the parasites develop inside the blood cells in the early year time, it forms a ring. So this ring, it has to get more matured. This matured where it has the trophocytes and schizoid. So it radically altered the structure of the core cells. Then now, when the parasite digests the cell's hemoglobin to feed itself, leaving behind a toxic crystals. This is that stage. Then it becomes more critical. Now the parasites itself, it remodels the surface membranes of the red blood cells. After remodeling it, it produces thin and sticky knots, of which we are going to look at the first step. Now the first step is cytoadherence and mechanical destruction. Once the Plasmodium parasites matured into the trophocyte and schizoid inside the red blood cells, it expresses a thicker surface protein called protein 1. This is a Plasmodium falciparum erythrocyte membrane, protein 1. These proteins act as a molecular, causing the infected red blood cells to stick to the endothelial lining of the small blood cells. This is cytoadherence, and to other non-infected red blood cells. So, by sticking to the blood vessels, the parasites avoid being sucked into the spleen, where they could be destroyed. However, this causes massive log jams in the capillary, blocking normal flow of blood and depriving vital organs of oxygen, or tissue hypoxia. Now, step 2, accelerated chemolysis, or the red blood cells destruction. Now we look at the intravascular. As the parasites replicate inside the red blood cells, they laterally burst the red blood cells open to release new merocytes into the bloodstream. Then now, when it goes to the extravascular, this is where it happens in the spleen. It goes to the spleen. Now the spleen recognizes that the surviving red blood cells have become rigid and deformed due to the infection. The splenic microbiasis works over time or very hard, destroying both infected and healthy standby red blood cells in a massive quantity. Now we look at this third step. This is in the cascades into the target organ, like the kidney. Now, the sudden explosion of the red blood cells floods the plasma with a toxic amount of the free hemoglobin. The kidney tried to filter these debris or parasites very hard, but the high concentration of the free hemoglobin causes oxidative stress, forms obstructing case in the renal tubes and cut off a local blood supply, that triggering acute tubular necrosis. Then we look at how the liver got infected. Now the breakdown of the hemoglobin that releases massive amount of unconjugated bilirubin. Then the liver's processing pathway are completely overwhelmed, causing bilirubin to build up into the tissue, of which it damages the liver. Now we're going to look at the laboratory investigation. Yes, rapid diagnostic tests for malaria done and Plasmodium falciparum positive, confirming malaria etiology. Then blood smears for malaria parasites. Results indicated high parastemia populace, confirming high parasite slot in the blood circulation. Complete blood count done, hemoglobin 4.2 gram per deciliter. This confirms severe anemia, of which is a life-threatening condition. Platelet count also done, of which is 4,500 liter, of which there was severe thrombocytopenia, which means the white blood cells are broken down due to the parasite infection. Then urinalysis also done microscopically. Then there was a dark blood. No, it was a dark plus 3 plus. However, no red blood cells on the microscopy. Confirms free hemoglobinuria or hemolysis rather than hematuria. Then serum, yes, the serum creatinine is also done, and creatinine slightly elevated, 140 millimole per liter, of which 1.58 milligram per deciliter, indicates acute kidney injury in this case. Then random blood sugar, 1.8 millimole per deciliter, of which indicate severe hypoglycemia, of which is a common metabolic complication of severe malaria. Serum total bilirubin, yes, 68 unit millimole per liter, or that is to say 3.9 milligram per deciliter. This one indicating hepatic dysfunctions and intense hemolysis, arterial blood gas and blood latex, pH 7.2 and carbon dioxide 11 millimole per liter, and the latex 6.2 millimole per liter. This result indicating severe metabolic acidosis, lactic acidosis, and severe hyperlactemia. Then blood grouping of this child was done for A positive. Then ultrasound services also rendered for the child. Then the results are 118. The liver enlarged with 18.9 centimeter. Then the spleen indicating 15.7 centimeter. This means the organs are enlarged, which means they are hepatosplenomegaly in this case. Then we are going to look at the immediate management of this person. Yes, hypoglycemia correction. 75 mils of dextrose 10% was given intravenously. This one is to establish or to correct prevent recurring of silent and drop in the blood sugar. Malaria treatment is also given antimeter 45 milligram intravenously given to this baby in first contact 12 hours for 24 hours. Then this atosine is being continued 24 hourly until when the child is able to tolerate oral therapy. And then the seizure control. There's also administration of diazepam, 0.3 milligram per body weight, of which 4.5 milligram of diazepam was given intravenously slowly. This one is to arrest and control active convulsion in the child. Not only that, even blood transfusion is also been commented. This transfusion was started and it ran smoothly. 300 mils of whole blood cells have been given, the red blood cells, and this have been transfused in 4 hours. Slowly to been covering 4 hours. But before that, there was furosemide been prescribed. It was 2 milligrams been given to this child. This one is to mitigate circulatory overload. Again, even antibiotics have been prescribed to this child to control or to prevent any opportunistic infection. Now, intravenous ceftriaxone, 80 milligram per body weight, of which 1,200 milligram was given. This one to ensure optimum tissue and blood-brain barriers penetration. That's why the dose has been increased, because severe malaria temporarily compromised the child immune system, especially depressing microphage functions and the ability of the body to clear bacterial pathogens from the bloodstream. And in this, sometimes this condition will be leaving the child vulnerable to a opportunistic bacterial infection like bacterial meningitis. That is the reason behind this, of which the child is given this ceftriaxone. Then nursing care. We are going to look at the nursing care or nursing intervention. So one of the nursing intervention is a strict fluid balance monitoring. And this fluid monitoring been monitored using a pediatric urometer. This is to measure hourly urine output, and the most target is to get a maximum of 1.5 kilograms per hour. This is because the patient has leaked capillaries and renal failure already. Now the fluid was managed on a strict knife edge to prevent pulmonary edema. And then another intervention is neurological care and air safety. The child being maintained in a left lateral position. This is to safeguard the airway from aspiration or obstruction. This is by turning even the patient every 2 hours to prevent also the pressure sore or injury. Then another intervention is frequent bedside glucose screening or monitoring, checking capillary or the blood sugar every 2 hours. This is being done because severe malaria blocks hepatic glycogen synthesis. And even atosinates can stimulate insulin's release, making this person highly vulnerable to profound asymptomatic hypoglycemia. Then terminoregulations or managing of the temperature is also put across. Managing this hyperexia using this paracetamol and even gentle tape sponging being done with the lukewarm water. Because this severing increases or the hyperexia increases metabolic oxygen consumption and can also lower the seizure threats. Now, another medical intervention, nursing intervention is administration of the prescribed or else correct administration of the prescribed treatment and the blood product. These drugs are being given accordingly to their doses, to their time, to their routes, and well documented. And again, also the blood products are being the blood products are being given accordingly. Well monitored drops according to the weight, according to the duration of time, according to these meals, the 300 meals. Then not only are being monitored closely. And from the beginning, it was monitored hourly for the first 4 hours. Then 2 hourly for next 2 hours. 6 hourly for next 8 hours. Then it was monitored 12 hourly in the next following 24 hours. This is to monitor and to detect any deteriorating condition in this child, even to evaluate hypersensitivity reaction to the drugs and the blood products, of which is very dangerous. Not only that, we are going to look at the complications of this case: cerebral malaria, the common and recurrent generalized seizure resulting from microvascular clotting, localized hypoxia, and increased intracranial pressure in the brain capillary. Severe malaria anemia. These are participated by drop in the red blood cells, mass due to the rapid hemolysis and splenic clearance. Another complication is acute kidney injury. This damage and acute tubular necrosis caused by the massive burden of filtered free hemoglobins, coupled with poor renal perfusion. Then the last complication is severe lactic acidosis. Systemic metabolic acidosis, this is secondary to the tissue hypoxia and anaerobic glycolysis. Though this is not the last, but could be the last now, if this condition deteriorated, lastly it can lead to acute respiratory distress syndrome because these conditions are very dangerous and can end in life-threatening conditions. Conclusively, urgent metabolic stabilization of the child by correcting of hypoglycemia with the 75% mix of dextrose intravenously, and again also correcting of this severe malaria with the 300 ml whole blood transfusions takes a priority, as the metabolic stress can cause rapid death for these anti-malaria drugs to take its effects. Now, lastly, vigilance nursing care is that the survival of this child depends on the balance of the strict pivotal management, because the child already has a hidden injury or compromise, of which capillary are leaked, and the fluid takes output must be properly monitored. Thank you. This is the end of my discussion.